Welcome to episode 12, health. And I think, I still feel some of these are pretty straightforward. Diagnosis, early intervention, that's obviously medical. Diagnostic assessment, screening services, time-limited, recovery-orientated services, where the predominant purpose is treatment, or that are provided after a recent medical or surgical event, pharmaceuticals, biological medicines, vaccines, sunscreens, weight loss, equipment or assistive products prescribed or issued as a result of clinical care that don't relate to the person's disability, surgical services or procedures related to aids and equipment, acute, subacute emergency, prescription, spectacles or contact lenses. And I know I have people that sometimes get paid the difference. So we've had people that have to have special glasses that relate specifically to their disability. So the NDIS pays the difference from what the glasses would have cost. And I think that still happens. Nursing services where related to treatment of a health event. Ambulance services, health transport services, hospital in the home services. And that will be relating to things that are not disability related.
Short-term treatment.
Yeah. Sleep consultant services, health retreats, newborn follow-up, hearing services or supports provided by a hearing services program, surgical services for hearing, subacute palliative care. That'll be interesting, that one, including inpatient and outpatient services delivered in the person's home or clinical setting. NDIS supports for the participant that may continue to be provided at the same time as subacute or palliative care services are not included here. So there are instances where the NDIS does cover costs for health for palliative care.
Can we have a life raft as the title for this specific section? Because there's a lot of stuff there that we know they're health responsibilities, but a lot of it's been pushed to the NDIS in situations where there's critical risk to people with a disability, or mainstream services haven't had adequate service provision or specialist accommodations for people's disabilities.
Yeah.
Interesting fact that I found last night from the Fry report that went into the NDIS review looking at the financial impact of the scheme. The mortality rate for NDIS participants is actually highest on the first year in the scheme. It's about 13% higher than average, and that comes in from what they attribute through to palliative care needs and people accessing the NDIS for support when they're living with a terminal condition like cancer and the like. Now, I feel it's quite sad that people have to go to such extreme lengths to have critical healthcare needs met.
Yeah.
And to be able to live and pass with dignity.
I mean, there's a bigger issue here, right, in terms of healthcare and expenditure and that kind of thing. And this is always a real point of angst between health and NDIS, this argy-bargy about who's got responsibility and who should be paying for what. And this is something that, sometimes comes back to plan managers of all people, where the participant might say to the planner, well, where does this fall? And the planner will actually say, well, it depends if your plan manager will pay it or not. Which is, it's not the role of the plan manager to determine that. Exactly. Okay, well, we ended up having to pay that back. But it isn't clear. There is a memorandum of understanding between the states and the federal government about, health, state health care. And
Is there?
Well, there's a very loose document.
It's a complicated relationship.
Yeah, and there's a document, but it's still unclear.
Yeah.
And so it's a tricky spot.
And the palliative, for me, because I work with quite a few palliative people, when I first saw palliative on there, I was freaking out. But then I saw that they will actually do the palliative, because some of my people, I had a woman with CJD, for instance, that was a specific disability. We had palliative people in. One of my participants now, he's we have engaged the palliative care team, but there's going to be a point in time. He's one of our 2-to-1 supports. At a certain point in time, he has disability needs as well as the palliative needs, and they have to all work together. So I'm glad that it does say that they may continue to be provided at the same time.
I've got a big philosophical question for you both. Do you want the good news or the bad news first?
I'd always go the bad news first.
Bad news is we're probably going to have to go and redo this whole conversation in about December, January. The good news is we've got an opportunity where there's issues with the lists to feed that back through to the government, because this is only the transitional agreement.
Yeah, that's
There's
right.
actually, at the moment, there's no agreement with the states as to what they're responsible for other than the APTOS agreement.
Yeah, well, we all know that this is not the
This is
the
basically
end. This is the for now.
This is the federal government drawing a line in the sand saying we're not funding this.
Yeah.
And trying to get the states to
Fund the
buy in.
therapy.
Yeah.
I don't think it'll be a foundational support, but we'll leave it to the states to decide. Yeah.
Yes. I mean, goat therapy would save on the cost that they're doing for lawn mowing, because just give everyone a goat. They can have a pet and they can eat their lawn at the same time. Problem solved. They'll just save lots of money. Yeah. Okay, awesome. Well, I think that was actually a lot faster than I thought it was going to be. Thank you for watching episode 12.